Good afternoon, friends. This will be a course on DMEK made simple for the beginners. And I am Dr. Samar Basak from Kolkata, and there are other co-instructors with us. Dr. Rajesh, Dr. Namrata will be joining soon, and Dr. Revati Rajaraman. And we have our guest faculty, Dr. Audrey Rostov. She is from USA, and she looks after the skill transfer courses in India in many places. So she will be giving on DMEK versus Dissection case selection and complex cases. Dr. Audrey.
Thank you so much. Where's this? Thank you so much. It's a pleasure to be back here in India and face-to-face to see everybody again. These are my financial disclosures, none of which are relevant to the presentation. So to DMEK or Dissect, that is the question. How do we decide? DMEK, as we know, yields better vision, quicker recovery, less rejection in the select cases. Patient considerations, though, need to be considered, such as the age of the patient, the cornea status, is there a previous PK, the lens status, current IOL status, is there a history of retina surgery, and such. For DMEK, I find that the straightforward cases work best here. Those with an isolated endothelial issue, such as Fuchs or pseudophakic bullous keratopathy, minimal stromal edema, a patient, for example, who may have a multifocal or an EDOF lens and then requires some sort of endothelial cell replacement, these are perfect for DMEK. More challenging cases include those with deep anterior chambers, such as high myopes, those with previous retinal surgery like vitrectomy. Also, you need to assess need for IOL exchange. This is also a more challenging case, and also post-PK. For cases that are more appropriate for Dissect, this would include patients who have large iridectomies, aphakia, glaucoma shunts, or present of ACIOL. DMEK requires a good view. And so to make life easier for yourself and your patient, if you have a good view, then a DMEK is a really nice option. Dissect you're able to do with a really cloudy view. I look at a Dissect as basically a slam dunk in a lot of these complex cases. Oh, sorry. Can we get rid of that? I don't see that on my screen here. It's not on my... No, I know, but I don't see it over here. I'm so sorry. I don't see it. Apologize. Uh-oh. Okay, there we go. That's a lot easier. Thank you. And it's now not advancing. Sorry, it's, apologize here. Let's try this. There we go. When we have patients who have a previous cornea transplant, a previous PK, and especially if you have someone who had, say, a TPK and not an optical PK, this is someone where an endothelial keratoplasty makes a lot of sense. It's less invasive. You can get good vision recovery, of course, if it's appropriate. In EK after a failed PK, of course, it's less invasive. If you're doing a Dissect, you don't have to strip Descemet's membrane. For a DMEK, you do, in fact, have to strip Descemet's. You want to be sure, though, that you avoid the graft-host interface and junction there because you can pull it apart. And I also like to use a smaller graft as well. Let's see here if this video is working. Yeah. Great. Don't know why it doesn't work on my screen. Anyway, in case of a previous cornea transplant, I always like to measure with calipers. You want to make sure that your Dissec or DMEK is a smaller diameter compared to your PK. And I like to undersize by about 1 millimeter. So if I had a previous 8 millimeter PK, then what I will do is do a 7 millimeter graft. For Dissec, you can strip about the same size, and for DMEK, I go slightly larger. That's why I mark. And whether it's a DMEK or a Dissec, I still do the same thing. I make my 3 paracenteses, and I really like to have this little Decimase membrane stripper, this Desmetorexis forceps. And it just does a really nice job of being able to both score and remove Decimase membrane. The nice thing is that if there's pus, if you have the synechia there, it's very, very gentle. Synechia are best managed being cut rather than pulled out, because then you can get an intraocular hemorrhage, and that will make life more difficult for yourself. You can see how Decimase membrane just comes right out there. Again, I like to undersize my grafts for EK by about 1 millimeter, and that works very, very well. With a Dissec, in this case, I like doing just a simple 30-gauge push-in technique. You always have a 30-gauge needle. I don't use a glide unless there's a large iris defect. And then I go on top of the graft on the stromal side with a little BSS, irrigate that, and then the graft opens nicely, as you can see here. For a DMEK, it's essentially the same as any other DMEK that you're going to do. Here we have the Dissec, and then suture the wound, of course, and then I add, and I put in usually a little bit more to secure the wound, and then adding a nice air bubble. With a DMEK, it's basically the same. What you want to be sure of is that if the graft won't unfold, it's either upside down or there may be fibrin in the way. If you do too much tapping, you're likely to get some fibrin, and so therefore you just want to watch that. Either way, though, you can get a very, very nice result. Here's an OCT and a clinical photo. You have to be careful, though, with your air bubble management for both Dissec and DMEK in a previous PK. This is a case where there's a rupture of a graft wound. So this is the previous PK, and there you can see that ruptures. It's not that big a deal. I mean, you can, of course, go and resuture your PK wound, but it is a bit inconvenient. When you have a patient who has a large iris defect or aphakia, I like to put in what I call a stay suture, and this is suturing the donor lenticle to the previous PK, and you could see in this case where there was a detachment that the only thing holding that lenticle in place is in fact the single stay suture. Here's the, and I'm trying to do the video here. For some reason, it's not going. Anyway, this is a case where I'm showing a, let's see if we can get this to go. This case here, still not going, that's all right. It's a case where I have to do a superficial keratectomy. I am now removing the a hazy foul Dissec graft within a PK, lack of iris, and I put what I call a secure or safety suture. You can do a suture guide, and I apologize for the, let's see here. It's working on my screen, but obviously not up here, so we'll just go on. And now that appears to be kind of stuck. Sorry for the for some reason, it won't advance. It's just frozen here. Yeah, it seems stuck. See, it's going here, but not there. That you're just moving the video around on the slide. See, it's not, sorry. Okay. It's also, I uploaded the thing as well. It's uploaded there as well. Let's see. Oh, here we go. Okay, that's fine. And so this is what it looks like post-operatively, that same case. It's not moving here, but I'm not going to worry about it. All right. This is a case in terms of looking at a previous DSEK. When you have a failed DSEK and then you decide whether you want to do a DSEK or a DMEK, I like, again, using this nice little Decimase stripper, and you can easily just remove that failed graft. And in this case, again, repeating the using the DSEK replacement graft. So if you have a failed DSEK, do you do a repeat DSEK or a DMEK? Well, again, that depends. There we go. It's always nice to have IT challenges. If it's graft failure or a traumatic DSEK, if it's a younger patient, a phakic patient, and there's a good view and minimal coexisting morbidity, then I like to replace a DSEK actually with a DMEK, and that really works quite well. If there's a more challenging view, if there's an ACIOL, iris defects, previous retina surgery, or a glaucoma tube, then I'll tend to replace it instead with a DSEK. If there is an opportunity to need to do an IOL exchange, for example, sometimes what I actually do is if there's a displaced ACIOL, I'll remove the ACIOL that's causing the problem, and then I'll put in a DSEK graft, let things clear, and then after that, following that, I'll go ahead and do a scleral fixated IOL. The scleral fixated IOL then will have a very, very nice view, so you can actually see well enough to perform that. Due to time, we'll interrupt that video. Again, with a DSEK, if there's a well-placed ACIOL and that's stable, then you don't need to replace it. But if, as in the upper picture, there is some issues there, then it's best to replace it. Glaucoma tubes, glaucoma shunts. When I first started doing DMEK, I would do DMEK on absolutely anything and give it a go. However, we know that with previous glaucoma tube shunts, your life of your endothelial keratoplasty is only really about 3 to 5 years, and so I just do a DSEK now. Otherwise, it's expensive potential wasting of tissue, and they only last a few years anyway. So in summary, DMEK, if you have a good view, previous PK, phakic, or a failed DSEK with minimal comorbidities, I like to do a DMEK. And a DSEK I reserve for more complex cases. DSEKs are very, very straightforward, and you can give a very, very nice result, even in the most complex cases. Thank you so much.
Thank you, Audrey, for nice cover. Sorry for the disturbances in audiovisual. So you have started with the indications in both DSEK and DMEK, where you should not try DMEK, and you have already mentioned that there are certain indications where we should go for DMEK, but there are certain indications, probably in later stage when you are experienced enough, you can try those cases. So this is the course of ours, DMEK Made Simple for the beginners. And you know, the difference is obvious. One eye, right eye patient has DSEK and left eye is DMEK. And you know, the satisfaction level, both for the patients and the doctor, treating doctor, is very, very high. And if you see that DSEK is always 80 to 120 micron more, so it is not perfect anatomically, and also visually we know over a period of time. So DMEK is perfectly anatomical, and there is more chance of getting 20/20 or 20/25 vision, and perfectly anatomical. So I will skip some of the slides because I've already made, but this graph is very important. This is US data, US data, you see that 28 data I could not find out, if Audrey can tell, but 21 data is there in the website, and you see that gradually over last 10 years, there is from 3.2% to 47% shift towards DMEK by the US domestic surgeon. And you see that again, Dissection is gradually reducing from 21,000. Then it peak was like 2013-14, it was 23,000, now it is 15,000. So DMEK is getting popularity. I believe that in India, 100 plus surgeons are using EK, mostly Dissection, and many people are doing DMEK, and the figure we do not have, but maybe overall EK is 4,000 to 6,000. So I will go quickly, already mentioned by Audrey. I will skip this slide. I'll come directly to one of the indication is like some of the contraindications for the beginner, that if it is a total aphakia, large pupil, vitreous in SE, you need a very good vitreoretinal surgeon, those who can fix a scleral fixation or retrofixated IOL, then extensive pass, and otherwise there is visibility is poor. And there are certain contraindications. Even in PBK, we see, you've seen the right side PBK, the corneal thickness is 1500 microns, so you cannot do Dissection in those cases. So DMEK indication in Western world is FECD, 80% cases, the range between 60 to 80%. Pseudophakic corneal edema is like 15 to 20%. And other indication which Audrey has shown us that is around 15%. So this is the overall scenario of Western world. When you come to India, this is from our hospital published, we see little more Fuchs dystrophy in eastern part of the country, and the percentage is around 36%. But other parts where we have discussed among our colleagues, the percentage is 15% and 80% of thing is pseudophakic bullous keratosis. The other indications are there. We do not get many CHD patients. Rajesh has a beautiful series of CHD, but we see a lot of ICE syndrome and post-HSB endothelialitis, and we have published our result. So these are two group of people. Post-PK Dissection we do, but again, all depend upon what Audrey has explained that thing. Workup is very important. Mostly, I used to maintain an Excel sheet. You used to pre-operative details of all the things, and you need to dilate the people in pseudophakic bullous keratopathy, and you need to know what is the lens status, whether it is in the back, in the sulcus, whether it is 3-piece, whether it is single piece IOL, because in multi-piece IOL, if it is in the sulcus fixation, DMEK graft unfolding may be difficult in some of the scenario. And you see the dilatation of the people, you must see if post-EAC cases, large EAC done, because, and post-vitrectomy cases where you do not find, and AR tends to go behind. So previous glaucoma surgery already discussed, lens status. Then retina status is also important. I believe that there are a situation where you need to know whether vitreous is there in the anterior chamber or the not. And before starting the case, you may put a little bit of triamcinolone in the anterior chamber and check. Or a small bubble, you try to rotate the eyeball and you can see the bubble movement, how it is going. And pre-op investigation like USG B-scan, axial length for biometry, and there are one-eyed cases, you need to know the spectacle history also, anterior segment photography for documentation, Anterior segment OCT gives good clue about subepithelial scarring. And post-PK cases, you need to see the posterior host graft junction status, anesthetist clearance, and macular OCT is very important. If you have get a scope of doing a macular OCT, especially in PBK cases, that there are a lot of reports are coming, and mostly these are pre-existing. So patient always blame that you see that graft is absolutely clear, still the vision is not coming. And if you see that macular OCT post-op, you will discover there is a chronic CME. Before operation, you have a scope, like mild haziness, you may get pick up. Then at the same time, you can give STK or other intravitreal injection. Then phakic corneal edema, cataract surgery, or no to cataract surgery. In our part, as a rule, in our hospital, we used to do if the patient is 40 years and above, DMEK IOL straightforward. If that less, then we may do in 2 sittings, first DMEK, then later on patient come. But in eye syndrome cases, even in younger age, I used to remove the crystalline lens because you get a little work to play because a lot of synechia is there. So sometimes you need to clear remove the crystalline lens. And cataract surgery after DMEK, it's not difficult, same as like routine cataract. Take extra precaution with cohesive, dispersive viscoelastic. And the surgery, the IOL of choice, like mostly I prefer hydrophobic acrylic, and usually no to YOLO lens if the other has got YOLO. Usually no to multifocal. If the other has got multifocal or multifocal bullous keratopathy, I did DMEK, then second I prefer multifocal because of all this. And toric IOL if the astigmatism is more than 2 or 2.5 diopter, and target usually 0.5 to 0.75 myopia. And this is also important if you have to get a scope of doing specular microscopy of the other eye. You need to know there are a lot of undiagnosed Fuchs is there, and a lot of those patients coming from comprehensive ophthalmologist to your clinic. And it actually shows the patient, yes, there is no fault in the treating doctor, cataract surgeon, it is fault in your eyes. So you can guard your colleague, and it is good practice, so you must practice that. So that is the part of indication, and I will go straight towards the donor preparation. Donor preparation, I know that the first hurdle is donor preparation, and US surgeon, though Audrey is sitting here, 80% of the surgeon used eye bank prepared tissue, and they always say they are spoiled. In fact, EK surgery in US start in their eye bank. Pre-steep, pre-stamp, pre-stent, preloaded DMEK graft is available, and they are hugely expensive. In India, I believe that most of the surgeons are preparing their graft. I do not have any knowledge that any eye bank is preparing and shipping to any other surgeon. But donor damage during graft preparation, what I can understand from discussion of different colleagues, it's between 1 to 4.3%. So different techniques are available. A classical manual peeling technique, stripping, peeling from the trabecular meshwork, peeling after creating a superficial refined cut, scuba technique, pneumatic dissection, hydro dissection, lamellar dissection, etc. But whichever is best on your hand, you do that without damaging the donor. So my simple manual, these are my instrument. I used to prepare donor during my surgery, and all are readily available. And this I always prepare just before donor insertion. So during recipient preparation after inferior PI, I give air tamponade for 5 to 7 minutes because of oozing of blood to prevent those oozing. And It also clears the edematous cornea to some extent. So I get time of 5 to 7 minutes, and those 5 to 7 minutes I used to do the donor preparation. It also saves my time. So this was my classical technique, otherwise 9.5 millimeter partial trepanation, handheld trepanation. And then I used to remove the peripheral DM. And if this sign if it comes very easily, that means this graft will behave very good and it peels very easily. So I do use Trefine Blue lot of dot. I do not use BSS. It is under, so it is like this, it's go by one hand technique in one go, little bit hinge at the other end, then do a 3 millimeter punch, reflect back the DM, reverse it, then soak that oil with the sponge. This has to be very meticulous, otherwise there will be smudging of S marking, and then flip it. Normally 8 millimeter graft, and you just remove the peripheral redundant part, take this graft over the corneal stroma, you just stain it for 1 minute, maybe less than 1 minute, take in an injector system, and your thing is ready. This is the other thing I use. This is a 37 years donor cornea. I have used this, not so sharp. It is just kind of like chopper, but tip is little blunt. I try to separate, because younger one, this donor DM endothelial edge getting is very difficult. So I try to get once you get the edge, you can go 360 degree without any radial tear. You have to be very careful. One hand, you do not require other hand. You just go slowly, and you just separate the edges from this 360 degree. At least 270 degree, if you do it, then your job is done. Sometime you may get stuck, so you start from the other area. This is younger donor. I have stripped as young as 17 years old, but very difficult to peel them, and sometime donor damage might happen. And this movement is very important. You see that there is side-to-side movement in compared to previous one. This is I practice in younger donor less than 50. So you go up to the just 1 to 2 millimeter hinge, and you see the typical tight cigar-shaped scroll. And we have published our result, and different sizes are mostly 8 millimeter graft, 63% of the cases. Believe me, my more than 1,000 cases, only 7 tissue damaged, and those 7 tissue I have used for other purpose. So once you are accustomed with this, it is the easiest part of just overcoming this hurdle. So we have also given a thought of peripherally trephineated DMEK. That means periphery, we know that endothelial cell count is more, and we used our iBank technician to mark 12 o'clock position, to mark, and it was published in, this is almost same, only this difference is when you complete this peeling, you see that you are one side. I purposefully for this study we use superior peripheral, but you may choose any peripheral. Peripheral always gives to, more endothelial cell to your this thing. And if you see that one side it is 1 millimeter and other side it is 3.5 or maybe 4 millimeter. So this is a concept. Those who are doing may try and see their result. And this is my same patient, one eye and other eye. This is 2016, 17. You see the donor density is, post-op density is so much, sometimes so satisfying. And this is another during pandemic. This is doubling the utilization, BCL interface rate. This is again published in this thing. And normally we have this kind of because we are making a hole of 3 millimeter, but for during pandemic, we need to, the first part is same, but second part, I used to make a BCL, resize BCL, make a hole of the BCL of, that, so that resized is 10.5 or 11 millimeter, and we negotiate that BCL in between stroma and epithelium. This hole actually make for that S mark. So if you go that, it is just to save the, so you make like this. So you negotiate and you soak the thing and you flip the BCL, the stroma remains intact, and you just dry it, put an S mark, and your whole stroma, 9.5 millimeter, is beautifully placed. So this is another, whenever same day posting DALC and DMEK, we used to do, even now, we published our result with 47 cases. I think we have crossed 100 of such cases. Take-home Moses's DMEK graft preparation is not so difficult, require backup tissue for initial few cases. Any media, MK medium, cortisol, optisol, GS, any media you can initially take help from the master, watch YouTube videos. It is always thrilling to do DMEK peeling with some adrenaline rush, and you may need practice and practice. So Rajesh, I'll go for basic steps.
Oh, okay, fine.
Because this is donor preparation, basic steps. I'll skip some of the slide because the basic is again already shown by Audrey. And you know that pre-op preparation is always same, almost same. Subtenon or perivalvular block. You know the difference between DMEK and Dissect already there. So DM scoring need to be little larger, DM scoring in DMEK. And inferior PI mostly mandatory, but many people are reporting differently. So I am also trying that, may not be necessary for all the cases. Anterior chamber should remain shallow during your donor interaction. Graft transfer is easier in most the cases. Unfolding is difficult, so typically the marks helps us in dark brown iris and Indian late presentation cases. Donor centration is easy in Dissect. I am telling you, this is one of the difficult part of DMEK, and everyone has their own trick, but it doesn't play it for all the cases. And never ever try to over-enthusiastic to center it more and more. That is my learning, that you should not over-emphasize. If it is little eccentrics, it doesn't matter. And air injection almost just air fill, not overfill. Just air fill is the right terminology for DMEK. And usually flat supine position, 1 to 2 hours. And this may vary from patient to patient. So I am skipping all these because all are done. So the main incision, I always go a little bit posterior limbal or maybe posterior scleral. So mostly sutureless is in most of my cases. Then DM scoring, you know that. But inferior PI, you may use both the technique, whichever is available to you. But you must be very careful. Rajesh will also share that with vitrector, you might damage the goniole and vitreous may pop out in some of the cases. I had in one case, so it is very important. And oozing of the blood, immediate air tamponade is very important to this thing. So donors, and this part actually Rajesh will tell everything. He has many kind of this thing. My view, insertion techniques, some techniques are difficult, some are easy. Some techniques may give better in terms of endothelial cell loss. Probably the principle remains same. Choose a technique which is consistent in your hand with good outcome, then master it. So injector, I always use simple, I am skipping that. And this is my usual technique of, mostly I follow same technique again and again and again, mostly, 95% of the cases. So I rotate the graft in horizontal. I always operate from superior head end of the patient because of some, this is, you see that the S is reverse. So here you have to give a little, gush of BSS, not heavily, so that it rotates automatically. Then you are perfectly at the central position, and then you make it center. I do not put any suture in the main dune in 99% cases. And when you know that it is center, then you give air, try with little air, and try to see your S is right or not. And when you are right, then you may give little more air so that, and you see that S is right. So immediate care is very important. Keep the patient in the recovery room, maintain supine position. This is my practice. Examine under slit lamp. In sitting posture, you see where is the air bubble. If it just above the inferior PI, you are just fine. Ask the patient to shift into the ward for again 4-6 hours. If it is not, it is PI is covered by the air, little burping of air from the one of the side port by 30 gauge needle or McPherson forceps, immediately you find that there is an air level and you are sure that there will be no pupillary block glaucoma. Earlier we used to keep the patient overnight. In pre-pandemic day, we have, because of pandemic situation, we have changed our whole system and there is no overnight, so we usually discharge the patient after 4 to 6 hours. Thank you for your attention. Now Rajesh will share his talk, different insertion technique.
Can I have my slides? Thank you, Samar, for making me part of this course, and thank you for simplifying DMEK surgery. The way you showed your presentation, your videos and everything, I'm pretty sure 99.9% people in the audience will be pretty sure that they can perform a DMEK surgery quite easily. I have no financial interest to disclose. Now, in terms of injectors, you have shown some of the customized IOL injectors, but there are dedicated glass injectors as well for DMEK, like the goiter injector or the modified Jones tube. You have the endoglide, and I do have some of these videos which are available on YouTube, which shows how you can convert various IOL cartridges and use them for DMEK surgery as an injector. And even Georgia Surgicals has now come out with a glass injector. If you can visit their stall, you can take a look at that. I think they are the only company that's still investing something into corneal devices. None of the other companies want to do that. In terms of loading, you can load it directly from the tip. This is easier to perform if the scroll is kind of tightly closed. But if you have an open scroll, then it may be a bit challenging to load it. Make sure that your nurse keeps filling the well with fluid. Otherwise, before you get the scroll into the tip of your injector, you can run out of fluid and you may have a scroll that's partially in the tube and partially outside. Or you can put the tissue into a petri dish or a bowl with fluid, and then you can load it from the tip. Make sure that your syringe is moving freely and it's not stuck. Otherwise, what happens is you get a sudden vacuum creation, and you find that the donor comes into the barrel of the syringe rather than in the tip. To avoid that, don't use a 5cc syringe. You can use a 2cc syringe, so the amount of vacuum generated at the tip is less compared to a 5cc syringe. I prefer to load it from the posterior wider end when I use a goiter injector, because I feel it's a much more gentle approach, and your donor tissue does not scrape the edge of your injector as compared to when you're loading it from the tip. One other way of loading it is that you can use a forceps, lift up the donor scroll, and directly load it into the injector, either from behind or from the tip. And this can be performed quite easily, and by the capillary action, you find that the scroll just goes into the injector. The basic steps are it's a fluid-based flushing system where you inject BSS. The problem is that sometimes, depending on the volume of the anterior chamber, you can get an increase in the anterior chamber depth. The pressure in the anterior chamber rises. First of all, your donor scroll has greater space to move, so you can lose the orientation, whatever orientation you are trying to put the scroll in. There is leakage from fluid from the anterior chamber once the pressure rises. And as you're trying to remove the tip of your cartridge, if you're not very careful, you can have a partial or total expulsion of the donor scroll. As you will see in this case, there is upthrust. I'm trying to get the donor into the eye, and if your primary wound is little larger, if it's leaky and you have fluid leaking out from there, you can have the donor scroll trying to come out. So you have to be careful. You have to loosen the speculum, ensure that the chamber is not very tight, and when you're injecting fluid, don't try to inject all at one go. You can slowly inject. You can release some fluid from the side port to maintain a low pressure within the anterior chamber, and that will allow a better insertion of the donor tissue. Now, we published our technique of insertion and unfolding. So the ideal configuration is a double scroll with the open end of the scroll facing upwards. So can we achieve this? Yes, if you have a donor scroll which has some amount of elasticity, you can, by agitating the fluid within the injector, you can get the scroll to open up, and when it re-scrolls, it can go into a double scroll configuration. And we found that in about 85% of the eyes, trying it 5 to 6 times, you can achieve the double scroll configuration. It's difficult in very younger donors where it goes into a single scroll, and also very difficult in older donors where the tissue does not have the elasticity to try and get into a double scroll configuration. And the other thing that we tried to do was to see unidirectional flow. So we use the AC maintainer for that. The AC maintainer is connected to the anterior chamber. The flow is on. That keeps the chamber well formed. Then you insert the tip of your injector into the anterior chamber, so you don't engage the iris when you try to keep the chamber shallow and you insert the tip. And then we rotate the tip, ensuring that the open end of the scroll is facing up. At that point of time, the AC maintainer is discontinued, so there is no flow into the anterior chamber. And then before you insert the donor, you ask your nurse to disconnect the AC maintainer from the IV tubing. So then your AC maintainer acts as an egress point of fluid from the anterior chamber outside. So when you inject the donor, as you will see in this video, as you're injecting the donor, you find that the donor goes in to the eye in a very controlled manner. It maintains the original orientation into which you have inserted, and as the chamber shallows, it prevents the donor scroll from going into any of the other configuration. And you don't have a tendency for the tissue to try and rush out from the eye because the pressure within the anterior chamber is low. And then to unfold, it's just basically a double scroll configuration is the easiest to unfold. You can do peripheral tapping and get the open end of the scroll to open up. And for us, just like Dr. Basak showed his technique, that he's very comfortable using that maneuver, and it's kind of reproducible in a majority of the cases. For me, this is the kind of technique that I go to. I try to inject into a double scroll configuration, and on an average duration of about 4 minutes, under 4 minutes, we are able to open most of our graft. And because of this reduced manipulation within the anterior chamber, in the small series that we did, we found that the endothelial cell loss was also lower. Now, this is a very nice website by patientready.org from Peter Wellman, and this shows you all the various configurations that a donor scroll can achieve, and there are tips on how to unfold them. Now, for me, that's how I used to do it initially, but now when you're injecting the donor, you always try to look at the tip of your graft and the open end of the scroll. Even if it's a single scroll, that V that you see, that should be facing towards the surgeon and not towards the iris. And you try to maintain this orientation once the tissue is inserted into the eye. Always remember that the open end of the scroll facing upwards is the right orientation. Now again, watch this video where we are putting the tip into the eye, and then we rotate the tip such that the open end of the scroll faces up. Now the AC maintainer is stopped and it's disconnected from the IV tubing, Now when you insert your donor into the eye, you can see it goes in a very controlled manner, and it's not rushing away to different part of the anterior chamber. And to unfold it, you just give a few taps to get the scroll to open up. You center the graft. As Dr. Basak mentioned, that a perfect centration is always not the best. Although we try to achieve good centration, but if you are dealing with a complex case and the graft has opened up but it's slightly decentered, it's better to leave it at that, because sometimes when you try to recenter, you lose the stain and you end up with worse than what you started off with. So these are all in real time. You can see the insertion and unfolding, and it's pretty reproducible. So if you look at all the videos that are playing, they are from consecutive surgeries, but so this is kind of a standardized technique. So once you get the hang of it, you will find that doing a DMEK surgery becomes very reproducible, because you are putting your donor in the same orientation every time, and you just need to use a few taps on the surface to open it up. You don't have to flip the graft over. You don't get a origami-like configuration, or you don't get, the graft getting displaced to the angle and those kind of problems. But let's look at some of the other techniques. So the common technique is where you tap in the periphery that creates fluid waves that allows the graft to open up, or you can release fluid from one of the side ports, and the egress of fluid from the side port also allows that fold of the donor DM to open up. If your graft is in kind of a fold like a taco, and so you can give a short burst of fluid to flip the taco so the open end of the scroll faces up, and then you can basically do the same peripheral tapping maneuver to get the graft to open up. So here you can see that we are doing peripheral tapping. I always like to use two cannulas, because one cannula is used to press at the limbus or in the peripheral cornea, which allows the opposite end to become deep. And whenever you let go of that cannula, the chamber shallows. So that way your, the chamber stability is maintained and your graft does not go back into a rescroll. You can use the Dissection maneuver, which is the carpet rolling maneuver, where you fixate with one cannula and use the other cannula and play like a drumstick onto the cornea, and that can be used to open up the scroll. This is very useful when you're using a younger donor tissue in a phakic eye or shallow chamber. You can do that. If you have a very deep chamber, then you can use the air bubble within the scroll to help you unfold the graft. So basically, in a deep chamber, because of the increased volume, every time you try to shallow the chamber, it's not possible. The chamber remains deep, and the graft keeps opening up again and again. So in that situation, you can always use the air bubble to unfold, but be careful when you're removing that air bubble. Try to remove it very slowly, because if you remove it very quickly, again the graft will re-scroll. You can use a pull-through technique, just like a Dissection graft, where the graft is folded inwards, and then you deliver the graft into the anterior chamber. This is useful for conditions where you may find it difficult to flip the graft, in cases like with the ACIOL, or if there are a lot of peripheral signs here. So this is the post-op appearance. You can see even by 1 week post-op, the graft has become completely clear. This is another case where we are using the pull-through technique. I'll just speed up the video because of lack of time. So you can see that we get the graft into the eye, but sometimes, depending on the flow of fluid in the anterior chamber, it may be a little difficult to control the way the graft maintains its orientation. So we do surface tapping, but we don't let go of the graft because we don't want the graft to flip over. And once that's done, we place an air bubble below the graft. That's again the same patient. You can see by day 5, the cornea is already looking much clearer. Even this kind of complex scenarios. The S-stamp is good, but you can do other ways of putting this triangular notch in the periphery. The surgeons from move fields, they use that in their practice. So looking at the orientation of that triangular notch, whether it's moving clockwise or anti-clockwise direction, you know that your graft is in the right orientation. You can use Roman numerals marking 1 or 2 in the periphery, and when you join these two, this should be moving clockwise when it's in the right orientation. There's another one where you can put an air bubble within the fold of DM to mark, so you don't need to use a three stromal window. So just to show you, so this is where we have done the partial peel, like a 70% peel of the DM. Then with a 30 gauge cannula, we just go within the folds and put an air bubble. So now you have an air bubble that's within the fold of the DM scroll. And once you have done that, you can just dry the fluid, and then you can use to put a, let me just speed it up, yeah. So you can use your, here you can use using a Sinski, you can just use that to create a stamp. So that way, you don't have to use a contact lens, because using a contact lens can sometimes be very cumbersome, because the contact lens dries up very fast, and if you're not quick enough, you will find a crumpled DM and with your donor DM sticking to it. So here you can find that you can use that air bubble. So this technique was again described from Mark Terry's group by Mike Strico, and we found that this was relatively easy to use. If you have access to an intra-op OCT, you can definitely use that to look at the orientation of a scroll, even in hazy corneas. So that's the future. I think when you have this, the surgeries will be even easier to perform. Thank you for a patient hearing.
Thank you, Rajesh. Wonderful coverage and a wonderful talk, and as always, it is so much admirable by me. My telephonic guru is Rajesh. I always, okay, Rajesh is the rush to go. I think next speaker is Namrata, but while she will be in a few minutes, so we can take some question then, because we have a lot of time now. Then, any question?
Sir, I have a question.
Okay, okay.
Dr. Siddharthan nowadays is not even using anything, just as we are peeling and folding. At that time only he makes the mark.
Okay.
No contact lens.
Nothing,
no this
nothing.
thing.
So everyone has got his own innovation, I mean. Any comment, Audrey?
Yeah, some very nice presentations. I had a question for you, Dr. Samar. I know that you really like to use the peripheral cornea because of the cell count.
Yeah, yes.
And was wondering if you'd found any difference in the posterior astigmatism, if the astigmatism changed because you're using that area, and if that made a difference with posterior.
I have the similar kind of, I have, though it is a small group, 50-50 in each group, central versus peripheral. The refractive part I have checked, there is no difference in posterior astigmatism. If you have question, yes,
I have,
Abhinava.
I have one, sir.
Yes.
Sir, it usually happens to me that my graft is stuck in the wound. Usually means it happens as usual. So how should I handle it?
In the wound, you said. No?
Yes, sir, wound, and it prolapsed to some extent outside also.
That is, Rajesh shows that is very important. Before injecting your graft, you must be sure that the AC is shallower side, or you may have put some AC maintainer, and you need to go little, your tip of the cartridge should go beyond the internal incision of the your main incision. So thereby, and when you, after completing injection, if you feel that AC is filled, so you take a forceps or any instrument in the left hand and try to release some aqueous before withdrawing the main, injector system. That way your AC will be shallower, and during injector withdrawal, you must have pressed the main lip. Rajesh has beautifully shown that it has to be guarded, otherwise the half of the thing may come out.
I think that a couple of good teaching points there, as was said. After you inject, you deliver the graft. You're not in a rush. Wait just a moment. So deliver the graft, but don't be in a rush to pull out your injector system. Wait a moment, okay, and then you'll see the graft there. That will also allow things to shallow, and then use another instrument, okay, just at the tip as you're withdrawing your injector. you're using a second instrument, and that will prevent it from going out. You have to make sure, of course, your injector tip, whatever delivery system you're using, is into the eye itself, and as was said, not just at the lip of the incision. The other thing is that if you're feeling too much resistance as you're injecting, too much resistance, then stop, okay? Because then that means that the eye is overpressurized and you will have it shoot out. So, you know, you're not in a rush at this point, okay? There's you know, the fire brigade is not coming. You just need to take a moment and be sure that there's not too much pressure, number one. Okay, fine, there's not too much pressure. Inject, and then just have a moment and wait. And that should really help with that issue.
Yes,
Good morning,
Abhinav.
sir. Just one question. Whatever we are discussing right now is what I have seen is usually with the older tissue, and that is not usually the problem. The problem usually is when we are using younger tissue that's around 50 years of age and there is a single scroll, then how to unfold it, if you have any tips, because this is something which I feel is the most difficult part in younger tissues.
In terms of the unfolding?
Unfolding, yes.
So if your graft is not unfolding, there's only really a few reasons it's not unfolding. And so it's really quite simple when you think about it. Either, number one, the graft is upside down, okay? Number two, your chamber is too deep. Or number three, there's fibrin. I guess there's a fourth, which is that it's too large. But once you know, there's only a few reasons it's not going to unfold, and I would say that usually the first 5 reasons are all that your chamber is too deep. So make sure the chamber is shallow enough, and then start your tapping, okay? And then I think you'll find it a lot easier to unfold. But make sure, I bet your chamber is just too deep.
So even if the chamber is shallow, it, let's suppose, opens around 50%, and then again it folds back to its normal position.
So yeah, so
That is the trick.
younger tissue will do
younger
that.
tissue.
If you just do small injections into the incision site of BSS, you know, or your cell line, you have small injections, little bursts of fluid, you can get the graft to be more floppy.
It gets floppy and then again it folds back. That is the problem.
So initially, this thing actually you cannot, each case actually behave differently.
Yes, sir.
It is very difficult that what she said, a little bit burst of fluid at the center of that scroll, wherever you, but always protect your main incision, because this tight scroll usually comes out very fast. So that is one, and what Audrey has said, that absolutely but again the best tissue is between, 55 to 65 is the best behavior, and initially I think that is the beginner surgeon should use those, and gradually when you get experience, you will find your own trick, how it is very difficult to describe it. And it may be different from one case to another case. Tight, very tight scroll. I cannot still explain how I have used 17 years tissue. It is so tight. But it opened in one direction, I give injection, it opened beautifully, that time shallower. And then I didn't lose that shallowness, so that I know if I make it little deeper, again it will be. So in shallowness, I just tap, and many people have different kind of injector, though go inside the tube, hollow tube, and they have, Rajesh is also, he has not shown this today, from two sides the fluid jet, and Sarnicola has one side, right side, left side. There are different ways, but same thing happens if you inject what little bit of jet of BSS from the into the tube, into the hollow part, it opens, and make sure that it remains shallower in that position.
I think as soon as you're injecting it and it starts to open, you have your second instrument, so be ready to trap it, okay, from the top of the cornea. So you inject, and then you see it starting to open, and then what's going to happen is as you're injecting and you're adding more fluid, the chamber will deepen. So with your second instrument there on top, right, make sure that you're able to trap it, and then you can withdraw, okay, and it's partially opened, and then you can start tapping, and then from your paracentesis, whichever area is not opening, shallow from there, and you'll see it start to open.
So when you trap, you basically put something from the top
Yes.
and just
Yes.
make the graft attach with the iris. Means almost it is in the contact with the iris, and then
Yes.
you flow it.
Yes.
Even the people used to tell that younger tissue better. I mean, in fact, the manipulation is more. I try to analyze my figure that what are the endothelial cell loss and younger tissue. It may be more because you are manipulating for more than 15 minutes or something like that. Sometimes it opens so quickly, you feel happy. Sometimes you are stuck again and again. And fibrin thread is one of the threat that it will not open, you may lose that graft. I had 3 occasions I had to discard that gap. So can we go with Revati's? Yeah, because then we can discuss when the Namrata will come, she will join. So Dr. Revati will be talking about complication and management of DMEKs. She will be talking something.
Yeah, just
So-
last question. Madam, do you use the inferior PI always? That's for her. Ma'am?
Audrey,
Sorry.
Do you use the
PI.
inferior PI in all your cases?
I'm
Do you use the
Inferior
inferior
PI.
iridectomy?
Oh, inferior PI,
in
sorry.
all the cases?
Yes, in all of the cases, I use the inferior PI. What I do is I go through my inferior side port, and then I just, with a little toothed forceps, like a LIMS or .12, I go in, I take just a little bit of iris, and then you can use a Van Ness scissors, or I have a little
Audrey,
micro
you didn't
scissors.
do any extra port.
And then I just do a very small, PI, rinse with some BSS, and,
Because I have not been doing it for the last 100 cases now, and really I do not have much problem without a PI. So that's my own personal experience.
yeah, I just always do the PI, and I find that visually, I've never had a patient complain about
it's not
it
a question
either.
of visual,
Yeah.
but some amount of bleeding, maybe fibrin, etc., might come out
You
through that.
can do in clean cases, 7 days prior, you can do YAC PI in those cases. Pure cases of Fuchs dystrophy, central Fuchs. Yes, Dr. Revati.
For again giving me this opportunity. And so far you have seen the surgeries by masters where we will feel so easy to do DMEK, but I'll also share my experiences or others who are in my category who are still learning, so we may come across many problems. The first thing was what we should understand when we are switching over from Dissection to DMEK, that these 2 techniques are entirely different. And what we have learned in Dissection, we can't apply directly to DMEK. So it's like switching over from manual CCS to FACO. Entirely different techniques we have to learn, and some of them we have to de-learn what we have learned in the initial Dissection. So starting from the tissue preparation, we have discussed this already. This is only for demo. I used a very old age donor cornea, where you can see the cornea will behave like a piece of plastic paper and easily break. So initially we may prefer a little older tissue so that unfolding will be easy, but preparing a donor tissue may be very difficult. And not only there, even it can occur even in masters like Siddharthan's hand, where obviously looking like a good cornea, but at the last stage when he is trying to release it from the cut piece, and there also like, the tear occurs. So sometimes we may end up with some small tags or a tear, but still if you have about 80% of tissue, you can still go ahead and do the surgery. Like still we can escape from by doing transplanting this graft. And coming to the recipient side preparation, we have to remember that this is a very less forgiving surgery. Like we have to remove all the tags, if we are using visco, nothing should be there in between the recipient area and the graft. So I prefer to do it under air whenever possible, so that we can see the tags at the edges easily, so that we can remove them meticulously, so that the graft adhesion will be better. And this, we have just discussed the tissue flying out. See this, as mentioned previously, the surgeon is trying to close the wound also, even then, as like, no, it just flew off. So it can happen, but luckily that the surgeon was able to retrieve the tissue and went ahead and got a good result. And I want to share one more thing, like it can happen anytime. It need not happen only after injecting into the anterior chamber. As the surgeon was just checking the orientation and other thing, it just came out. So we have to be very careful. Sometimes this also can happen. And poor visualization is another problem as we are unfolding the tissue especially. So this can happen in long-standing corneal edema, or if the tissue is not stained well, or due to manipulation it got destained. So this is one another example. Like now you can see a lot of edema, so it's hard to even make out the tissue there. And then as the surgeon trying to, that's it, the graft is gone now. We don't know where. I think it went actually into the pupillary area, through the pupillary area behind the iris, and later he was able to retrieve and use it. But still, sometimes this can happen, and especially if the view is not good. So that we have to keep in mind. And the unscrolling, again, the same, the doctor asked this question, this kind of a cigar-like tightly scrolled tissue. So I think Rajesh Fogla described this some time back. So I used to enter the scroll area with the cannula and a small burst of fluid. We can unfold it. And if you are very confident about the orientation, we can even try to use that to unscroll the tissue. And sometimes a large, especially large graft can be folded like this, like a origami graft they call, and then we have to first straighten it before trying unfolding it. That sometimes it may be difficult. And this bleeding, again, we have to be very careful. I don't have a video to show how difficult it will be to stuck on tissue to manipulate, but we have to be careful. Whenever there is a bleeding and wherever you touch, you have to be careful. And I too also, I am not a big favorite of this PA, from where this ooze can happen. So nowadays, sometimes I totally avoid PA also. And there are some reports that without PA, we can go ahead and do the procedure, or we can go for a YAC PA. Again, this inverted triangle Dr. Rajesh was talking, but still, even with all that preparation, I noticed that S was upside down. Then we have to deepen the tissue, anterior chamber, and then gently roll on the tissue within the anterior chamber, and then we have to go ahead and place it properly. So really, it has to be rolled on in the anterior chamber itself. Then we can go ahead and do it as normal. And a decentered graft sometimes can happen at the end when we are injecting air. The graft tend to go towards one side, and got this happen in Dissection also, but easily we can manage there by tapping. That cannot be done here. Again, you have to replace that air bubble with fluid and refloat it towards the center, and then go ahead and position it. And sometimes, again, this is another reason why I don't like PAs nowadays, especially somehow I tend to make a large PA. So I try to inject at the end the air. As I remove the air, I notice the air is again gone. Like you can see the fold of tissue at the inferior edge also. So it went behind the iris, then I need to again remove it and then reposition it. So this also can happen because of a large PA. So that's why nowadays without PA also we can go ahead. So the another problem, pupillary block glaucoma can occur postoperatively, especially if you leave behind a large bubble which you have not removed in time properly. And donor tissue dislocation is more in DMEK than in Dissection. And first we have to make sure that orientation is correct before to rule out why that this happened, to find out. And in the first week, any time it can happen. It may not be only the next day itself. Next day, what appear as a small, shallow detachment can progress to a larger detachment within few days. So we have to closely follow this patient, and then we have to go for a rebubbling. many people prefer smaller graft to manipulate, easy to manipulate, but then we can end up with peripheral bullae, so patient may remain symptomatic in these cases. Primary failure can be more than in DSEK, especially learning time. Need not be only due to the donor factor, it may be due to the very complicated recipient pathology also. Graft rejection is very, very low in DMEK. That's a main attraction for this procedure, but still it can happen, and very carefully we have to follow this patient to look for even appearance of small few KPs, and then we have to go ahead and manage. Graft infection is not so common here for us as compared to PK, but in the American Academy, the Eye Bank Association of America, according to them, the infections in EK is more than in PK. And as Dr. Basak pointed out, because the surgery starts in the eye bank, this is one of the theory that it may be because there it is handled and longer time and then it is transferred. That may be one reason. We don't know the exact reason. But it can happen. This is one of our cases from one of our center. Early seedling you can see, and within days it progressed. AIOCT clearly indicated that. Very difficult, because difficult to get the material even for the proper culture and identification. Mostly it is fungal, and Candida and Aspergillus are found to be common even in EBA study also. This case also was Candida. And the very important thing, we have to trace the mat tissue, the other donor tissue where it is being used, and then recall the patient and closely follow. That is very, very important, because in 2/3 of these cases, they can go for infection also. And in conclusion, this is a very elegant surgery, but we should remember that technically it is different from DSEK. So when we are switching over, we have to de-learn certain things and we have to learn certain tricks, which is very unique to DMEK. Thank you.
Dr. T, this is wonderful presentation and you covered all the complications. So I'll call upon Dr. Namrata Sharma to speak on AIOCT guided DMEK. So this is our last talk, and we have, we have exactly 12 minutes time to go. So I think time is perfect.
Thank you, sir. I would be speaking to you about intraoperative OCT guided DMEK. Not that you need it. Only thing is your surgery becomes a little more refined, and it helps you understand the dynamics much better. So there are no financial or proprietary interests. And OCT is a non-invasive diagnostic technique which renders an in vivo cross-sectional view of the optical tissue. And we have microscope integrated OCT, and I am going to be talking about that. The advantages are that it gives you real-time images, dynamic visualization, and continuous and simultaneous acquisition and display of OCT images possible. But of course, the flip side is that it is expensive and it may not be available at all centers. So you do the donor dissection and the host dissection. When you do the donor dissection, it actually does not, it's actually not required because the Descemet's membrane is already stained with the trypan blue dye. But sometimes when adhesions are present, then it helps to identify that on the intraop OCT microscope. And after the Descemet's membrane is detached from all the sides, trifronation mark is given, and then subsequently this pure Descemet's roll is then elevated as shown. This is a punch, a 3 millimeter punch which is being made, and once this is made, on this the Descemet's membrane roll is again slid back, and again the part of the peripheral part is dried a little bit so that to stabilize the graft. Now, following this, an S-shaped stamp is being made and looks like a desmetocele on the intraop OCT microscope, and this cover of this is then placed back in position, and then subsequently the graft is then dissected almost 8 or 8.5 millimeter and then this is placed in the Petri dish, which has the media. Now, this is a case of fuchs dystrophy for which the cataract surgery has been done, and now the Descemet's membrane scoring is being done. And again, if there are adhesions or remnants which are present, these can be seen on the intraop OCT microscope, and these can be adhered. And this is the Descemet's membrane roll, which is then injected in the injector. And this is centralized, and now you have to get this biceps curl upwards configuration. So this is absolutely upside down, and after putting in fluid, you get that biceps curl configuration. The graft is then unrolled, and following this, the air bubble is instilled, and the graft gets stuck to the back of the cornea. This is how, this was the case that I showed you, and looks quite clear. You can't even make out where the graft is following a DMEK surgery. Now, it is of special use in hazy medias, because in hazy medias, which is a reality in our part of the world, you can't see where the Descemet's membrane remnants are, and you can't even see the S-shaped stamp. So all the adhesions which are present or remnants which are present are addressed using the intraop OCT microscope. And this is again a Descemet's membrane roll which is then instilled, which is like a tight scroll. And then as you tap, it gets again into the configuration of a biceps curl upwards, and then again, you know, this is a correct side of the graft, the endothelial side down. Now, this is the same case that I had shown the video of. Then in hazy cornea such as this, orientation at times may become problem, and in this case, the graft is very much there, but its orientation is not correct. And like I said, the correct orientation is a biceps curl upwards. So when you get that, looking at the intraop OCT microscope, even though the cornea is hazy, one can still tap the graft to come into the correct position. And once you have that biceps curl upwards, the air bubble can be instilled. And even if when the S is not visible, you can put a blob of viscoelastic here. So as soon as you put a blob of viscoelastic, it gets magnified a little, and then you can see where the graft is. Now, sometimes there can be folds in the graft. Like in this case, the unrolling of the graft was done to get it into the correct configuration. S is also staring at you, which is absolutely fine. But then there are folds which are present here at the edge of the graft. So to undo the folds, you have to actually put the fluid between the graft and the overlying cornea, and then from the other side put the air bubbles. So this has now got completely unrolled out, and then you can see that there is no longer the fold which is present. Then in eye syndrome, again, it helps because there may be adhesions which may be present underneath. So again, the Descemet's membrane stripping is done, and the graft is placed in position. And when the correct side is up, one can instill the air bubble. I think it is very useful for eye syndromes because it has a dual purpose of looking at the adhesions as well as also unrolling the graft. Now, this is a case of failed DMEK for failed Dissect following penetrating keratoplasty. So just at as the graft is being removed, the Dissect graft, there are adhesions which are present between the underlying iris and the Dissect lenticule. So very gently, the iris adhesions are tweezed off, and again, when you're loading the graft, you can actually load it in the manner in which it should be loaded, with the biceps curl upwards, and then in the same manner, one can eject it out, again, taking into consideration that the endothelial side has to be down with the S, correct S looking at you. Now, this I called a case of auto DMEK because the surgeon did the surgery. The whole Descemet's membrane came out, and then he pushed back the Descemet's membrane inside and didn't know which side up. So he referred the case to us. The case was immediately taken up, and it was a challenge to understand which side is up and where is the Descemet's membrane. So I call it auto DMEK because this is the patient's own completely detached Descemet's membrane after 2 hours of surgery, which was referred to us. And then again, you can look at the intraop OCT microscope and see which is the correct side which is there, and then get the correct side to stick up stick on the correct side, and then alternatively, even if you don't have an intraop OCT microscope, you can stain it with a trypan blue dye also. But I think if you have an intraop OCT microscope, then it just helps, because that guides you a little better than the trypan blue dye. Then there can be problems with DMEK, all of which can be sorted out by the use of IOCT. Now, this is just to show that there can be problems in the sense that once you put the graft, you get the graft to go inside, it may be possible that it ejects out. Now, in this case, it has ejected out. So, it is ejected out mainly because your fluid has gone much before than the graft. So, adequate dock is very important, because if you have an inadequate dock, there is a gap wherein the fluid can push the graft outside. So, if you completely dock when you are actually putting in the graft, then this will not happen. So, your fluid has to actually be above your docked area and not with your injector. And the graft has to be loaded in the way that you load it with the correct configuration only. So to conclude, intraop OCT is a useful tool in the armamentarium of endothelial keratoplasty, in fact for all keratoplasty surgeon, because it helps to refine the DMEK surgery, and of course modifications and quantifications are required in the current system for accuracy. So thank you very much for your kind attention.
Thank you, Professor Namrata. Wonderful talk and wonderful demonstration. Especially, I like the auto DMEK one, that is so difficult and so challenging also. We have only 2 minutes left. Any question to Namrata? Anyone? Any question to any of the speakers? Any question? So no question. So there is no question. So thank you very much, the audience and other people. Thank you, Audrey, for staying back for our discussion. Your tips are so helpful for the audience and for me also. Thank you, Revati, also, for a wonderful. Come for a group photograph.